So this is going to be an overview of co-design. So for some of you, I think, who raised your hands earlier, this will be a little bit of a repeat, but hopefully you'll be able to help your team members who aren't so familiar with the process. So the aim of this session is the context and value and evidence base for working with staff, consumers, family and whānau, so why we're doing it. And it's about how to effectively engage with people as partners to improve services. And it's then looking at the process that is used to do co-design, so the engaging, capturing and understanding people's experiences, leading to some, we hope, improvement in services. So there's many different terminologies that we hear around this, and there is some overlap in them, but they are all slightly different. So we hear people talking about consumer or customer or patient experience, consumer-centred care, patient-centred care, co-production and co-design. So consumer experience or patient experience, customer experience, is the sum of all interactions shaped by an organisation's culture. And I think that's the really interesting bit, the bit about that these experiences are largely shaped by the culture of an organisation. So it's interesting to think, what is the culture of your organisation that is shaping people's experience, and that will then influence consumer perceptions around care or the care that they receive. So consumer-centred care, or it can also be called person-centred or patient-centred care. There are many definitions of this, but at the heart of all of them, they all describe an approach to the planning, delivery and evaluation of healthcare that is grounded in mutually beneficial partnerships among healthcare providers, patients, consumers and families. And then co-production. So this is the co-production more focuses on the implementation and delivery of a solution. And so in this definition, it's delivering public services in an equal and reciprocal relationship between professionals, people using services, their families and neighbours. So these are giving the definitions of all these quite similar concepts. So co-design, it was originally called cooperative design. It's also sometimes called participatory design. And its approach to design attempting to actively involve all stakeholders, so whoever the stakeholders are around your particular piece of work, and involve them in the design process, not only from the start but also all the way through to the delivery, to ensure this result actually meets their needs and is usable. So I'll go through the aspects of co-design, but it's a part of a process that to engage people and to capture their experiences and ideas, organise that learning into themes, which we'll do as part of this process, and then continue together in partnership. So it's not just hearing from people at the beginning, it's actually how do you involve people all the way along the process. So sometimes we have the tendency, health is not alone in this, in any service industry or any industry really, in terms of saying how are we involving consumers or stakeholders. We have sometimes that we don't listen very much and we actually go away and do the designing. And David Price from Waitemata DHB had a very good picture of this yesterday about a road crossing where actually there was a barrier in front of the road, and then people actually, it's called a desire line, that actually made a path in the grass around actually where it made more sense for them to go. So yeah, I don't think they did much co-design in the design of that pedestrian crossing. That we can sometimes listen to consumers and then go off and do the designing, so that's that little bit of tokenism at the beginning. We can also call consumers in at the last minute to comment. So we've done all the designing and say, oops, we missed that bit, so quickly gather your focus group or your consumers, just at the last minute. But then the point of co-design is that you're listening to the consumers from the beginning and then go off with them to do the designing, to do the co-design. And so there's a quote here from Tom Peters, who's a change management and leadership writer, who says, "The biggest mistake is viewing co-design as something you do at the end of the process to tidy up the mess, as opposed to understanding it's a day one issue and part of everything." So we hear from consumers about what matters to people, and I think this would probably echo what matters to any one of us if we're a consumer, that actually we want to be treated as a person, not a number, that we want to feel informed and be given options, want staff or whoever to listen and spend time with you, want to be involved in your care and being able to ask questions, and then we want efficient processes. And also the availability of support services, for example, consumer and carer support services. So there are a number of principles within co-design, and these are the ones that Waitemata have used in their manual. They're not the one and only, so you might have other documents which have other underpinning principles, but these are the basic core principles. That actually you need to prioritise the consumer experience, and it's easy to let consumer experience and priorities get subsumed by organisational and staff needs. But to counter this tendency, always to keep the consumer perspective at the forefront of what you are doing. So actually you need to intentionally prioritise it. You need to trust the process. So sometimes the tools might be ones that you're not very familiar with. And you might get frustrated that actually this is taking a long time and actually we just want to get on and do things. But actually it's really important to actually follow through the steps because the results will be worth it, because you'll get to an end outcome that actually everybody has been part of and agrees with. Because it is very tempting to want to rush, to not allow the time really for this process, because it sometimes can feel like it's slowing you down, but it really is worth it. And the means is as important at the end as the ends. So the social outcome of co-design work for like establishing networks is just as important as the output of the project. So it's just as important, that whole social aspect of it, as delivering on your new leaflet or your new mental health care unit, which is one of the examples I'll play a video of. And then it's also really important to acknowledge people's contribution to the process, so that it's not only consumers but it's also staff. So whoever's been involved in your co-design process, whether that's written recognition in reports or offering training or just acknowledgement of people. And I think Sean mentioned about COHA, that if you're inviting people to be part of your process, you need to think how you're going to acknowledge that, whether it's petrol vouchers, or I think there is a shared policy that I can put in your soft copy of your packs that Auckland District Health Board, Counties Manukau and Waitemata have a shared regional policy for the acknowledgement of consumers for COHA. So I'm happy to share that with you if that will be of interest, put those in your packs. So now I'd just like to play a video from, actually I forgot to do that at the beginning. I'd like to acknowledge Dr. Lynn Ma, who is based at Counties Manukau Koawatia. A lot of this material on co-design is from Lynn, which she shares quite willingly. But this is just a short video, a couple of minutes of Lynn speaking about co-design.
They can work together in every single way, but the important thing is actually they're working together to understand how the patient receives care and how the clinician, from any clinician's point of view, provides care, and understand how that feels for both of them, so that they can start redesigning services for the benefit of safety, quality, efficiency and patient experience. But it is about having the discussion together, spending time together and making sure that happens. It's really important that when we're trying to understand the patient journey through care, that we capture their experiences, and we use emotion words, so whether they're positive emotions or negative emotions, and then we start to gather those emotion words and connect them with parts of the process, and they're called touch points, and that gives us a really good understanding in terms of what's working well and what's not working well for the patient and family member for their experience. Then the next step is that once we've got that fantastic information, to again family members, patients, consumers and staff to work together to say, how are we going to redesign the services? Because if clinicians took that information and then started to redesign services, we do it from our perspective. Whereas actually we need patients and family members to be in the room learning how to co-design, so that we make sure that the end process is exactly how both patients, and family members need it, but also how clinicians need it, because we're both important in this partnership. But this is about making the shift from clinicians doing the designing to patients and clinicians doing the redesigning together, and that's the key.
So the focus of my presentation is really around the engage aspect of the co-design process, and then later on in the day we're hearing others speaking about the capture aspect and then the understand. So Dion in the afternoon will talk about the capture aspect of co-design, and then Ros will speak later about how we understand, or what we do with what's been captured. So the beginning phase with co-design is your project startup phase. So that involves your aim and your scope and your plan. So in aspects of the project startup is thinking about who you're going to have as part of your project team. So this might not necessarily, you might actually then have a separate co-design process, but actually involving consumer, family, whānau, who aren't necessarily involved as your ongoing project team. But it's thinking about who are you going to have in your project team. And in a couple of moments we'll go through that list that you've got in your packs. And then as part of the project startup is about defining your aim. So we're not expecting that you'll be doing this today, because that's part of this whole engage, capture, understand phase, that by the time we get to the second workshops in December, you'll have a much clearer idea of what's coming through your co-design, what are consumers, family, whānau talking with you about the adverse events process, where are the good points, where are the not so good points, what are staff saying about it, and then thinking about so yes, I'm just reassuring you that we're not expecting that today you'll know what the exact aim of your project is. But these are just some things for you to be thinking about in the days and weeks ahead. And also with anything that you're doing, have you got data to support it? Because in order to show that something's improved, you'll need to have what is your data, what's the story that you've got at the moment. So again, your co-design, the feedback from consumers, family, whānau, staff, that will inform the qualitative part of your data. But have you got quantitative data? So have you got numbers to have as your baseline data as well, so that we can see actually what changes that are going to be made have actually made an improvement. And so co-design helps to define the problem or the challenge from multiple perspectives. That's the aspect of all the data. So it looks at your collected data, which might be your quantitative data, and then looks at the experiential data, which is just as important, the qualitative data that you're going to be gathering from consumers, family, whānau. And then thinking about how you're going to prepare for your engage, capture, understand phases. So who are you going to involve, etc. And then that's just a quote here, that lived experiences is equal to other forms of knowledge, evidence and expertise. So I think traditionally, perhaps in medicine and healthcare, it's been quantitative data has been given preeminence, but actually we're saying this data is of equal value. So maybe I'll give you some minutes now at your table to think about your project team. So who's going to be your sponsor of this project? Because we know from our work with Zero Seclusion and Connecting Care how important that sponsorship role is. And actually we have a model sponsor here in our midst, Heather Casey is the sponsor of the Zero Seclusion Connecting Care projects at her DHB. So, I mean, Heather, would you like to just say a couple of words about your role as a sponsor and what that means and whether the difference for the project teams?
I've been a sponsor of Zero Seclusion in our local DHB since the start of the project, so I've very much learned as I've gone along. I think the key thing was actually reading the information that was given to us as project teams, because it clearly defines the role of the sponsor in the project lead, etc. So that was a good starting point for me. I think the main part of the role are about constantly encouraging and supporting the project team. I meet with our project team on a weekly basis. They're escaping me today because I'm here, but every Friday. Now I only meet for half an hour and I only meet with the project lead and our quality facilitator. So it's a very quick meeting and often only takes 15 minutes. So it's just checking in to see what the progress is, also what I can do in terms of support, and so what problem solving, what barriers, and just providing positive feedback. Any information that I have from the Quality and Safety Commission or any other avenue, so to they're fully informed. And the other major part of the role is actually reporting up, so ensuring that the mental health leadership team are well informed, of which I'm part of, but ensuring they're well informed, ensuring that the Director of Nursing is well informed, and right up to the CE. So because CEs are actually paying for the program, and so there is an interest in how we're progressing. Also, by reporting up, I can also be reporting any barriers and getting them involved in any problem solving. And then again, that information coming back to the project team, but also making sure that the information is getting out there to everybody that works and is part of the service. And Kath Patterson, who is here with us today, is our quality person, and she does a wonderful newsletter that informs people of what we're doing, why we're doing it, and our progress to date, and that goes far and wide.
Thank you, Heather. I think that was a really helpful overview of that. That really is a key role, and we can see where the teams who have an active, engaged sponsor, the difference it makes for them, just for that support. And as Heather said, that not only there are the being reported to, but the reporting up. So there's some key roles in the team. So the project sponsor, the project lead, who are going to be your subject matter expertise from the staff involved in your project team, who's going to be your consumer advisor, family whānau advisor, representative on your team, Māori health input. So all these roles are key, and we can, as I say, we can really see with our other pieces of work where people are able to have these roles engage, the difference it makes. And actually one of the roles which I think traditionally has not necessarily been part of these project teams is a data person, but again they're a really key person to have linked in. So even if they're not able to come to all the meetings, have you got a key named data person who you can go and have that, getting that quantitative data that can support your work. So maybe if you have maybe 5-10 minutes at your tables, just thinking about who's going to form your project team. And there's the two bits of paper there, one for you, one for me, to start thinking. And it's amazing how time goes by so fast. So it's thinking about actually how many hours per week are actually these people going to have available to be engaged. If it's really they haven't got any time, actually should they be like your clinical lead, for example, on your project team, if actually they have no time to be able to be supportive and involved in the project. So yes, maybe 5-10 minutes just for that discussion at your tables, and then we'll call back. Thank you. So the thing is then about thinking about the how of the engagement. So that there's no single right way or one way to engage people, but but that you need to think about sort of respectful and appropriate methods of engagement that are relevant to the people or group. So you'd use a very different way to engage youth than you would, I think somebody gave the example yesterday that they had tried to run focus groups with a group of youth. It was Dr. Hiran Thabru who came and spoke to us yesterday from University of Auckland, and he said that once they then started using an app, that the level of engagement was way better than trying to arrange, say, for example, a meeting or a focus group. So it's thinking about the methods and the ways that you'll engage those particular groups of people that are involved, or particular groups of people that are impacted. So, for example, if you're wanting to speak to people who've been involved in an adverse event, it's thinking about timing of that, in terms of, is it too early for people to be involved? So yes, just all those considerations that you need to take into mind. This is about then thinking about the people that you're going to engage, including consumers, family, whānau. So who might that person be? Why are they important to your group? What value will they bring to the project? What value will they get out of being part of the project as well? How many of them will you try to engage? So I think Sean mentioned this before, that it can be quite daunting for a consumer to come in, particularly those who have not been part of a project before. And actually Cassandra Lasky spoke yesterday, the consumer representative from Counties Manukau, about how they use mentors. So again, mentoring, if you're having a consumer that's never been part of a project group before, then perhaps mentoring them with somebody that has been before, that they can show them the ropes, because it can be quite daunting to come through into a meeting full of healthcare professionals with you as a lone consumer voice. So then they're thinking about maybe having two people involved. And where are these people? Where will you find them? Where is it best to engage with them? Perhaps not always expecting people to come to us. And again, somebody gave the example of that yesterday, that actually they're going out and meeting people in church groups or wherever in the community, not necessarily always having meetings at the DHB, for instance. And then who's going to engage with them from your project team? And when's that going to happen? Plus any other things that you think will be more useful. And then I have a quote here that a face-to-face request is 34 times more successful than an email. So somebody's obviously done some research about that. So next is a video from Counties Manukau Health, and it's about 4.5 minutes, and it's the video of the co-design process that they went through in the design and building and opening of Te Aho Mai, their new mental health inpatient unit.
Well, I go back again to our whānau. The discussions happened with her. The takis were given to her through the treatment of our people within the health sector. The mamais that were happening within the health sector needed to have a voice to be heard.
One of the most important things for her was that Māori maintained their mana. And so she was very clear with me about the building should represent the community. And the building should look like that it isn't an institute, which traditionally we know that hasn't been good for Māori.
We've come to this stage through a lot of help from people who have used the service in the past, the tangata whaiora and their families and whānau. They've been really important in helping us to identify what's important to them, and that's really been reflected in the design.
It's designed for people who are have an acute mental illness, who present with risks that are so great that safe treatment for whatever the issue is that they're presenting with can't occur anywhere else but in a hospital setting.
I mean, what was really important was that we replaced an old facility that had really, had gone well past its use-by date. And important that our staff, who are competent and capable and experts in their field, were provided an environment that allowed them to do their best.
It's really hard to change the way you practice in an existing building, in an existing facility, but in a brand new place you get a chance to think about, okay, how might we do things better? How might we practice, whether we're nurses, doctors, psychologists, social workers, OT, all of the people that work to support people in an acute mental health unit.
People are often frightened when they come in through the door, and with adults who are frightened, that manifests itself quite often as being angry. So we wanted people who are admitted to come in the door and think this is light, this is bright. We wanted to get away from anything being dark. We wanted them to have the feeling that the corridors are wide, the roofs are high, so there's a feeling of space. We wanted every service user who was admitted to have their own bedroom and ensuite. So in our current unit there are still shared bedrooms and shared ensuites, so we knew we didn't want that.
One of the most important things on a journey to wellness is our relationships with others. So the ability for staff and for families to interact with the service users who are in here is really important. So the design takes all of those things into account.
And as you look around here, the use of openness and the space will allow the wairua, the hinengaro, the tinana, and all aspects of wellness to find its place with the whaiora in their whānau.
I have to pay tribute to the clinical director and our GM and the team, the staff, who've really gone out and sought the input of mana whenua, of service users, of whānau, and importantly of staff. They've looked at international best practice, and they've thought about the context in which we are working in counties Manukau and the needs of our communities here. The sum of all those parts is so much greater than what we would have expected.
Yeah, so that's just a great example of a co-design process, and I think as Margie Apa says, the sum of it all is much greater than just the individual parts. So this is more, now we're thinking about the how of engaging with people. So the important aspects are that when you're going to be engaging with people, asking them to be part of your co-design process, so not necessarily now part of your project team, but engaging those people who you're going to seek their input on their experiences of adverse events and the process. So you need to be really clear about the why. So why are you asking for their input, and how are you going to do it, and what are you going to say to them? So a really useful thing to do is is called an elevator pitch. Has anybody heard that terminology before? Yeah. So basically, yes. What would you say to somebody if you had them in an elevator, and that you really wanted this person to hear from them and them to be part of your work? What could you say to them in the space of an elevator ride?